Okay. Well, we are right at 5, so I love to be prompt, so I'm just going to get us started. I know some people are still joining, but for those who are on the call, we're so excited to have you here. And if there are any questions throughout the event, feel free to throw those into the chat or the Q&A, and we will make sure to try to answer as many of those as possible. So thank you all for coming to today's event, your birth wish list. So the tips from our very own Dr. Amersi around how to get ready for delivery. So we're going to walk through a bunch of stuff, but before that, I'm just going to give you a little bit of background about Origin for those who are unfamiliar. So we are physical therapy for women and mothers, and really we are on a mission to try to improve the quality of care and standard of care for women across the country and feel good at really every stage of life. So we specialize in sexual health, pregnancy, and postpartum physical therapy. But at here, we just really believe that there is no such thing as TMI. So we'll have a lot of time for Q&A at the end of this event. And feel free, like I said, to throw any questions into the chat or the Q&A. And then from here, I'll just introduce today's speaker, who's Dr. Amersi. She is one of our absolute all-time favorite OBs at Origin and refers a ton of patients in and vice versa. But she's really one of the country's top recognized OBGYNs, graduated top 1% in her medical school. She's been chosen as a top doctor in the US for the last 4 years. And with about 10,000 babies under her belt, she has really seen it all. So we are so excited to have her talk about some really important topics today around preparing your mind and body, really getting your 3rd trimester checklist, and how to reduce the risk of C-section. So Dr. Amersi, I will turn over to you. We also have Dr. Sarah Clampett, who's one of our clinical directors in Los Angeles, our Brentwood clinical director, here to weigh in from the PT side as well. But Dr. Amersi, I'll let you take it from here.
Okay, thank you so much for having me and for everyone joining. I think I have some of my patients that are also listening in. They told me they'd be on here to support me, so thank you, ladies. When I think about childbirth, it's like training for a marathon. So you don't just show up on the day of the marathon with your running shoes and expect to do well. Like there's a process that goes along in preparing for it. And it's a physical process and it's also an emotional process because literally it's 2 things that are needed to get you through this amazing journey, emotional stamina and physical stamina. The most important thing for patients is to really start to feel prepared and to feel empowered. I always encourage my patients to use the word empowerment, that you're not alone in this journey. You have a physician who's going to be your advocate. You'll have your birth partner. You'll have a team of amazing nurses at the hospital. Some of our patients use doulas to also help them support them through this process. And the key thing is to just kind of gather that tribe early on during your pregnancy. So you have a team that's in place that will support you and hold your hand literally through this process. The most important thing is, we put so much effort into what to buy for the baby and baby showers and gadgets and things like that. But it's far more important to focus on like your physical and your mental health. So the first thing I wanted to encourage patients to understand is to accept the idea of pain and not to be afraid of it. When we talk about pain during labor, it's called labor for a reason. It is painful. Even if you're having a scheduled C-section, there's going to be pain from that. And pushing a baby out through a vagina, it's painful. Even if you get an epidural, it's not going to be like a yoga class or a day at the spa. It hurts. And so I tell my patients, go into this journey not being afraid of the pain, but almost re-transform your perception of that pain into thinking it's bringing you closer to meeting your child. And that's an incredible process. Like you'll go through some pain during labor, and I encourage my patients to do it 1 contraction at a time. So when labor begins, don't think that, oh my gosh, I'm having pain and it's never going to end. A contraction lasts for 30 to 45 seconds, and then you'll have a pause for 3 to 5 to 7 minutes even before you have your next contraction. So focusing on doing 1 contraction at a time is really key. And using tools that you'll get through birthing classes, which we strongly recommend every single person go through, especially for first-time moms, to give you an arsenal of techniques to help you with breathing, to help you with managing the pain, and also not being afraid of it, and using techniques to help you get through one contraction at a time. The most important thing I encourage my patients to do as they're preparing their body for birth is to manage their emotional stress. Starting at 32 weeks, the cortisol levels will cross the placenta, and your baby is swimming inside your hormones. So if you have high stress in your life, you're going to have cortisol levels that cross the placenta, and your baby's swimming in those hormones and is relying on you as the mom to tell the baby what world is awaiting them. So if your stress levels are high, the baby is anticipating a stressful world. And if your stress levels are manageable and you have more endorphin and joy in your journey of pregnancy, your baby's swimming in those endorphins. And that translates into the delivery. When the baby comes out, we find that patients who have high cortisol levels, their babies have difficulty with breastfeeding and latching, and they're a little bit more colicky. So managing ways to organize the stress, and we all have stress. It's so high in all of our lives, especially in the past year and a half for everyone going through the pandemic and job stresses and financial stresses. But using this time to learn how to manage it, whether it's through meditation, exercise is a big way to encourage stress management, getting fresh air every day, seeing a therapist if needed. There's no shame in having mental health care as part of your pregnancy care and not having any stigmas associated with that. I think almost everyone should engage in therapy of some sort to help them navigate their emotional health.
Dr. Mercy, on the like, just thinking about kind of the pain and are there any like birthing positions, or I know that was a top question that we heard sort of in advance, was really, and Sarah, maybe you would weigh on this too, but are there any kind of good either positions or effective kind of natural ways to reduce pain?
My big philosophy with my patients is to labor at home. So I'm a big fan of labor at home and deliver in the hospital. First of all, when you're at home, you're comfortable because you're in your own environment, so you can manage pain a little bit better. You're not in a foreign place. You can go in the bathtub and soak in a warm bath, and just the water and the warmth can really help you manage the pain. You can move around at different parts of your house. I think walking, sitting on a birthing ball and going up and down on that birthing ball really causes a calmness to the pain and helps with alleviating some of those discomforts. Having pregnancy massages, so if you have a doula at home or your birth partner, having them massage your neck and helping you with, breathing, and using music as well. Music is an amazing tool to just kind of focus on distraction a little bit, but also taking you to a place of joy. I think always music makes me feel happy and peaceful, depending on what you listen to.
What's your go-to playlist?
I'm a big fan of Coldplay. I'm not gonna lie. I have a crush on Chris Martin. I'm still not understanding why Gwyneth Paltrow ditched him. He's a great guy. So I'm a big fan of Chris Martin. I also like, my son calls it PMS music, but I really like Lumineers and Mumford and Sons.
Oh man, that's so cute.
Yeah, but just music that's fun and uplifting as well. So not like Enya and those types of songs. No, don't do any of that stuff. That's like, make it uplifting. And then also, a doula at home. I'm a big fan of doulas. You have to find a right doula, but somebody at home who can help you stay home for the early part of labor. Positions that work really well are the birthing balls, lying on your side with a pillow between your legs, and the bath is essential, just to soak in the bath and moving, like sitting on a rocking chair. Most people have a rocking chair at home for their nursery already. So I tell them, go on your rocking chair and just rock back and forth and back and forth. And that movement will just give you a sense of calmness. One of the things, moving down to number 4, which is breathing. Breathing is one of the biggest techniques to help you with pain. So whether it's emotional pain or physical pain, I encourage everyone to take breaths. And it's, we all kind of take it for granted about breathing. But when you're feeling stressed, when you're feeling pain, when I'm in the office and I'm doing a procedure on a patient, I tell them just focus on your breaths. And it's like a deep breath in, and then a longer exhale. And the longer exhale is just forcing your body to quiet down. And that works really well. And learning how to do those breaths every day, like sitting in a room for 10 minutes and just focusing on your breath and quieting your mind. Meditation, I've collaborated with Headspace on numerous projects, and Headspace or whichever meditation tool a patient's using, it's wonderful to just have that soothing voice and a guided meditation to help you through the early part of labor at home is extremely helpful. It just kind of takes you away from your mind and it avoids you having to think and overthink the pain and just be in the moment. And feeling relief knowing that the pain will end. There'll be an end to your contraction. You'll get a long pause, embrace that pause. And every time you have a contraction, it's bringing you closer to meeting your baby. So this is a good pain that's happening. It's not a bad one.
Yeah, Sarah, I know we focus a lot at Origin on the belly breathing, sort of anything to add there and sort of your tips as you think about what kind of breathing can really help?
Yeah, we have a lot of our patients who come in before delivery, like we'll teach them how to breathe, we'll tell them how to use that breath, like using that diaphragm, using those bigger muscles and trying to avoid some of those accessory muscles that tend to bring us more in our chest and our neck, and really trying to use the entire body to take those nice big deep breaths. And we'll also have patients practice those birthing positions, or we can teach partners like which part of the body to work on and how to do that massage during labor. So there's a lot of value that can come from learning that breath, and then also just kind of practicing before.
And then the key thing with going into labor, like if you're preparing for a marathon, you're not going to show up at the marathon, having worked nonstop 12-hour days, the weeks leading up to your marathon. You're not going to be going on sleep deprivation, and that's not going to succeed. So a key thing is to allow your body to get lots of rest. In our society, we're so used to going, and women feel uncomfortable just sitting and doing nothing. But there's a gift in that. This is not a sprint. It's, slow and steady wins the race. So when you go into labor feeling rested emotionally as well as physical rest, the last parts of pregnancy, the last few weeks are so uncomfortable for almost everybody, where they're just exhausted. They have aches and pains. And this is when it's a good time to even begin the physical therapy journey of starting to, circle over to the physical therapist, have them work with you on tools that can physically give you relief so you can get better sleep, working with you on your pelvic floor strengthening so you can get ready for the pelvic floor muscles that are needed for pushing, and making sure that you're allowing your body to be quiet and not feeling like you have to go all the time. There's a gift which is sitting and being patient and being in the moment. And then I think the most important thing to prepare your body for birth is to really minimize the noise from people around you. So everyone's got a story to tell. And I find after 20 years of doing this that people really love to share their horror stories about labor. It's amazing to me. Like I I'll be at my son's soccer game and I'll, unfortunately sometimes wear my scrubs with an OBGYN label on it. And random women who don't even know me will come up to me. And bear in mind, our kids are now 16 and 17. And they'll sit down and they'll start telling me about their birth stories. I wasn't their doctor. I'm there to watch my son's soccer game, but they want to go through all the details and they remember the details. It's amazing. Every single detail they'll remember and they'll share it with you. So I have patients that come in and they've been doing fine, and suddenly they've talked to somebody who's told them about a horror story of an emergency that happened or a baby that didn't do well, and those are the stories you don't want to hear because every delivery is different. And this is now your own story. And I tell my patients, politely just tell your friends who are well meaning, look, I really appreciate what you're, sharing your story. But at this time, I just want to focus on my journey. And I'm trying to just avoid having extra noise because I want to go into my labor feeling empowered. And know you can do this. Like if you are with the right team, there are a lot of unknowns with your birth and with the way your birth story is going to turn out. But I tell my patients, the two unknowns you're not going to have are healthy baby, healthy mom. And when you go into that feeling empowered, like I will be safe, I'm taken care of, I'm not doing this alone. I have a medical team that's taking amazing care of me. And the team involves you, like as the OBGYN, the nursing team, which are extraordinary. You have an anesthesiologist as needed. We have a whole staff of people that are there to help you and to surround you with love and nurturing and expertise, professional expertise, to make sure that you have a beautiful, safe journey. Because we have two patients we're taking care of, and we don't take this responsibility lightly.
I was just having this. I have a friend who's 35 weeks, and we were on a walk last week, and she was just saying the same thing. She was like, everyone's telling me all the awful things that are going to happen, but like, what if it goes well? What, why does no one tell those stories?
No,
So
all
definitely,
those stories, but they're the bad ones people share. And
I
I
know.
really think like you have to be empowered and say, this is, and I think it's mind over matter. Like if you go into this fearful and, if I have a patient that says, oh my gosh, I'm so afraid I'm going to die. I get nervous taking care of those patients because I'm like, that's not the way you should be thinking. Like you're giving birth, you're giving life. That's what we're doing. And as long as you're in a safe environment, we won't let anything bad happen to you. Yes, complications unfortunately can happen. That's the nature of our job. That's why OBGYNs have an extraordinarily stressful job. But we take this job very seriously, and we all come to this journey with significant expertise and a team that supports us to ensure that our patients have incredible outcomes.
Yeah, and I think sort of the piece that can help and where you've put together this awesome checklist is really just feeling like you're prepared and feeling like you have all of the, you're controlling for as much as you can control.
The most important checklist, and I think this shows up in a later slide that we might have, Allison, is you cannot dismiss the importance of finding a right birth partner. So that means finding your right birth provider, whether it's a midwife or, I'm biased because I'm an OBGYN, but finding an obstetrician that will be your advocate. So instead of feeling like you're going in there and then you have to like hire other people to help be your advocate with your doctors so that your doctor might say one thing and you'll disagree and you'll feel uncomfortable. Finding a doctor that shares your philosophy, of trying to do things maybe if you have a philosophy of doing things in a holistic way and really wanting labor to be as natural as possible, seeking out a doctor that will support that journey but will also guide you and navigate you in case things go sideways. The third trimester is the most important part of your pregnancy because this is when you need to be seen more by your physician. You need to make sure you're being more mindful about the pregnancy and that you're on call for yourself to know that when to call us if something doesn't feel right. At every appointment, I tell my patients, and I sound like a broken record, but you have to keep track of the baby's movements because you see us for, 15, 20 minutes for your appointment. But the way we both know your baby's doing well is by keeping track of the baby's movements. And every day you should count 5 to 10 kicks. And yes, the movements will slow down. Yes, they'll change a little bit, but don't start over analyzing the movements yourself. Like, oh, well, the baby's too big, so I don't have to feel the baby move. Or I felt the baby move yesterday, so I'm not worried. No, you should feel the baby move every single day. And if something doesn't feel right, trust your instinct. If something feels off, and I tell my patients, it doesn't have to be a specific symptom, but if something feels off, you're just not feeling good, reach out to your obstetrician. And the right obstetrician will listen to you and will either reassure you or help you with maybe addressing your concerns by doing some extra testing. Making sure that if you're a high risk patient, so my patients, especially who are older after the age of 35 to 38, patients who are Black, who are known to have complications with preeclampsia and high blood pressure, I encourage all of those patients to have a blood pressure machine at home and to check their blood pressure at home regularly. And then to call us if the numbers are elevated, and your OB can guide you on those numbers. I would recommend using this time to complete birthing classes and then composing a birth wish list. I really don't like the word birth plan, and we'll talk about that later. But a birth plan is like you're going to your doctor and saying, this is the plan and this is what needs to be done. I prefer to say birth wish list. Like, Dr. Mercy, if all things are going well and I'm doing well and my baby's tolerating labor, these are the things I really hope you'll honor during my delivery that are meaningful and important to me and my birth partner. And we go through those. And there's some things that might be a little bit unreasonable on there, and I'll I'll discuss my concerns with those patients. And if there are things that are important, I'm like, sure, let's do this. I'm open, and your doctors will be open, but just don't make that birth wish list like 20 pages. We will laugh at you behind your back if it's a 20-page birth list. Make it short and cute and easy. And I can help you guys with that today. You want to also make sure like you plan to stop working. So at least 1 to 2 weeks before your due date, take a break so you're not working till the last possible minute of having your baby. You know, I have patients that are on their laptops working away while they're in labor. I'm like, no, like put this away. Like, let's get rid of her Wi-Fi password. Like, she cannot be working while she's having contractions. Also, it's a good time to get a mini getaway and, have sex with your partner. I think, sex is great because it does help your body go into, the process of labor. It helps with orgasms, which gives you your feel-good hormones. And it also helps the vaginal tissue get more elastic, and it can bring on some early signs of labor, which are always good. I know this sounds silly, but I have OCD and I love my cleaning lady. So leaving for the hospital and making sure your home is clean. So when you come back, everything is nice and clean. You have a fridge that's stocked, and even setting up a meal train system with your friends so that the first few weeks, the last thing you're doing is worrying about food. I'm a big proponent of working with physical therapists and acupuncturists the last few weeks of pregnancy. This is like in my arsenal for all of my patients. I tell them, start working with a physical therapist. You're having back pain. The back pain and the pelvic pain are hard now. You're having a hard time sleeping. Going to the physical therapist early on will help you get some tools to help you with that discomfort. Also, physical therapists can begin the relationship with you. So postpartum, you already are plugged into their system, and you can continue seeing them for your postpartum wellness. Acupuncture is one of my favorite ways to integrate Eastern and Western medicine. So with acupuncture, you can work with certain acupuncturists that your OB can recommend that can help your body get ready for labor. They can do a lot of treatments to kind of trigger contractions, helping you with relaxation, helping you with fatigue, and even give you herbs and supplements that I encourage to help kind of start the process of labor, especially if you're getting close to your due date and nothing's happening. I'm a big fan of cord blood banking because that's great to collect stem cells in case, God forbid, in the future you might need it. And then most importantly, complete your birthing classes and breastfeeding classes as indicated. And then make sure you have a hospital bag packed. My patient who had a baby this morning, her husband was packing the bag like 2 hours before. So I would say just try to pack it earlier if you can.
Are there any must-haves that you would recommend that people include in their hospital bags?
I definitely toiletries, because the hospital toiletries, no matter which hospital you go to, they're not fun. So toiletries, a bathrobe, so when you're walking around the hospital, you're not showing your cute little butt to everyone that's walking around behind you. And then also like a nice blanket. I'm always a fan of being cozy. So I like having my own blanket, something soft and, comfortable. Music. I'm a big fan of music. So bringing some music to the hospital. And I think if you're being admitted for a vaginal delivery and labor, it's nice to set the mood. So, we always like dim lights. I think it just makes the room feel more peaceful. You can get those flameless candles that set a nice ambiance to the room. And even a picture of something that you can focus on when you're pushing. So like I tell my patients, have a focal point, like whether it's something that the baby's going to be wearing or a picture that's meaningful to you, something that's going to inspire you to like push and realize like, this is like, I'm having a baby, and feeling really excited about that.
Awesome. I know
And
you
hospital snacks. Oh, pack some good snacks, because I'm snacking at that hospital and it's like really graham crackers and vegetable broth soup, which gets tiresome. So pack some good snacks.
I know you mentioned that you had some recommendations for what to include on a birth wish list. What kinds of things, what are some like maybe good examples that are top of mind?
So I think we have a slide for that. I'm not sure if you made it, Allison.
Well, let's see. We can continue on. I'm not sure if that one made that in there. Let's see.
Should we do this one first, or do you want to go to the?
I think, I don't know if we have the slide on the birth wish list. So maybe if you want to just voice that over. That would be awesome.
Yeah, I have my notes down here. So what I tell my patients is the birth wish list should always be at the very top: healthy baby, healthy mom, least amount of intervention possible. Less is always more. So, when I was trained, I was taught by the most amazing obstetricians who wrote textbooks on OBGYN, and I was lucky enough to be trained by them many years ago. And one of my key mentors, he told me that, in your career, you should do two types of deliveries, an easy vaginal delivery or an easy C-section. So what that translates into is the delivery should be smooth. So if we're getting to the point where if we're in the process of doing a vaginal delivery and there's a concern about the baby's heart rate and it grows and grows, and then we're starting to do a lot of intervention to force this baby out, and the baby's telling us through lots of different ways that he or she's not coming out vaginally, let's not force the baby out vaginally. I mean, we'll do everything we can to encourage vaginal deliveries, but let's listen to the baby. I also don't like planning emergency C-sections. First of all, they're not planned. So it's like an emergency C-section is when the baby's heart rate is going down, 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 and you have to rush to the OR and you have to go from a skin incision to a baby in 20 seconds. And we do that, and we've been able to do that. But the adrenaline is too much. And I always prefer to have things be peaceful, whether it's a vaginal delivery or C-section. Let's make it calm and peaceful where everyone feels like they're able to breathe and things are in control. And so the way I practice medicine has afforded me those two successes. I'm either doing easy vaginal deliveries or easy C-sections. And sometimes when they're not easy, we still focus on our own breaths so we can take care of our patients in a calm way. The most important thing for the birth wish list is to really trust your OB. Imagine going for an appendicitis and then going to your surgeon and telling your surgeon, this is how I want you to do my appendix surgery. I want you to use these sutures. I want you to cut me this way. I want you to cut only this much. And then this is the size of the incision I want. I want this music playing in the operating room while you play my appendix, while you remove my appendix. We're the only field in medicine where we have our patients coming to us telling us what they want us to do, including surgery. I have had some patients to say, this is the sutures I want you to use. And it's very hard to kind of work like that. I always tell my patients, you're choosing us as your OB because you trust us. And that trust develops over 9 months of time. And I feel very confident and grateful that my patients, I would say 99% of my patients who come to me, by the time we're making big decisions during labor, they're like, whatever you want, Dr. Amersi, we trust you. And the reason why that trust happens is because patients are my partners. So I don't just walk in and say, bam, we're doing a vacuum delivery, or bam, we have to do a C-section. There's discussions that have happened along the way. So if ever there's concerns that manifest during labor, I always will speak with my patients and say, this is what's going on. This is what I'm planning to do to kind of correct the situation. And these are the different options. And we'll collaborate together on what the patient wants, and we'll cure her. And I think having patients feel heard is really important, because then they trust that they're a big part of this decision, because it should be a partnership. I always tell my patients, you and I are partners. We're doing this together. We both have the exact same goals. And so as partners, I'll bring my expertise to that partnership, and you'll bring your wish list to the partnership, and we'll make sure that that marriage works and that we have the outcome that we both desire. The first thing I encourage my patients on the birth wish list is labor home as long as you can. From the time your water bag breaks, don't come into the hospital. You don't need to be seen at the hospital. Stay home for 6 to 8 hours, because sometimes it takes a while for contractions to start. And if you go to the hospital too early, intervention starts to happen unnecessarily and earlier on than it should be. If you go to the hospital and your water bag's broken, more than likely, depending on who your OB is, you'll get started on Pitocin. You'll get an epidural then. You'll get the epidural too early. You'll get frequent pelvic exams that can cause infections. So labor home, you can manage your pain a lot better at home. Then when it's been 6 hours of your water bag breaking, go into the hospital. So the later you go into the hospital, the better it is for you. I always tell my patients, with the laboring at home, doing it, as we talked about, one contraction at a time. When you get to the hospital, Put on your birth wish list that you want to have intermittent monitoring. You don't need to be monitored continuously. So they can monitor the baby's heart rate for 20 minutes to an hour. And then for an hour, you can be off the monitor as long as the baby looks good in that hour of being monitored. And you can walk around the hospital. You have freedom to walk around. So I always tell my patients, put on your birth wish list intermittent monitoring. I also encourage my patients to put on their birth plan that if they do get an epidural, don't feel pressure to decide before you go into labor, I'm not going to get an epidural. I would say that write down, like, I prefer to do things as naturally as possible. But if I decide to get an epidural, I'll let you guys know. It's better than that than a nurse coming in every minute saying, hey, do you want an epidural? The anesthesiologist is outside. Do you want an epidural? It kind of negates your journey of trying to do things as naturally as possible. So if you write out a simple bit wish list, like I want a healthy baby, healthy mom, least amount of intervention possible. I want to labor at home, and I don't want intervention done unless absolutely necessary. 0 to 6 centimeters takes a long time. That's the early part of labor. It used to be 0 to 4 centimeters. So it's really important all patients listening to that know that that's changed. So if you have a doctor that comes in and says, okay, you've been 4 centimeters for 2 hours or 3 hours, time to do a C-section, wrong. It's not time to do a C-section. It's okay to wait as long as the baby's doing well. You can continue waiting. Have the patient walk around a little bit more, and then maybe do some things to start labor if she's not contracting enough. If we use Pitocin, I always tell my patients we'll use the least amount possible, but there are things patients can do that are natural if their labor is starting to stall out. They can do nipple stimulation, their partner can do that for them. We can leave them alone so they have some privacy, and those things work. And they actually can help bring on contractions. I had a patient a week ago, and we gave her a breast pump. So she was using the breast pump to help bring on her contractions instead of Pitocin, and she did amazing. If patients decide to get an epidural, I tell my patients don't get it too early, because if you get it in the early part of labor, 0 to 3 centimeters, 0 to 4 centimeters, it slows down labor, it slows down your contractions, and then you end up getting Pitocin. But if you get it when you're in really active labor, which means like 6 centimeters dilated or close to that, then after you get the epidural, you can rest. Your body's breathing, you can rest, get some sleep even. And usually we check you a few hours later and you're completely dilated. So I tell my patients, don't feel badly about getting an epidural. There's not a single patient who's in my practice who's ever gotten an epidural that says, I wish I hadn't gotten it. Never, ever, ever in history does that happen. Their regret is, I wish I'd gotten it maybe earlier. And in fact, they're so busy thinking the anesthesiologist at the end of the delivery. I'm like, what am I? Like, I did something here too. But they're so grateful for the anesthesiologist. And then for those patients who really want to do this without an epidural, we will support you. We will help you do it one contraction at a time. We'll work with you on different positions, breathing techniques, massages. So you're not going to just be flat on your back with monitors and being strapped to the bed. Our nurses are very skilled. Your doctors are very skilled to adjust positions so that your pelvis can open, the baby's head can come down faster, and to help you get through your labor. So you're not invalidating your wish of trying to do things without medications. I would say 10% of my patients, 10 to 15, do completely unmedicated births. And the key thing is to have an OB that's patient with you. You have to have a doctor that's going to be patient, that's not going to make you feel pressured about how long things are taking, because it can take a long time. Labor can space out, and it's okay if that happens. As long as you and the baby are doing well, you need to find a partner with you who's not going to come into your room and say, okay, you're 7 centimeters for 4 hours. We're going to do a C-section if you don't dilate in the next 2 hours. That's awful. That's a really bad way to put pressure on a patient. Instead, the doctor would come in and say, okay, you're 7 centimeters, you've been 7 centimeters for a while. Let's go through some options for why I think this is happening and what we can do to get you to contract a little bit more. And then the partner feels empowered instead of feeling like threats and pressure. You never want to feel pressure when you're in labor, especially not from your OBGYN. A key thing also that I tell my patients is to make sure your doctor's not cutting an episiotomy. There's no reason to cut an episiotomy. It used to be a very standard care of taking care of patients where you would have your perineum cut. And the thought in the old school ways was that you can repair the tear and it's straight. But I find that if we do a lot of perineal massage and warm compresses, patients do really well. And even if they do tear, it's much less than if it was with an episiotomy. And I don't cut episiotomies, maybe once in an entire year for like a true emergency where the baby's heart rate is going downhill and I'm very concerned about the baby's well-being. But short of that, I don't cut episiotomies. One of the ways to avoid tearing and to avoid tearing extensively when you are in labor, so to put on your birth wish list, is to have your doctor do the massages like with mineral oil or the lubrications we use, warm compresses while you're pushing against the perineum, and that really helps with prevention of swelling and tearing. But the best advice I can give anyone to listen is to do something that's called laboring down. So most doctors, when a patient gets to complete dilation, which is 10 centimeters, you're told to start pushing. But the baby's head is still really high up at that point. As soon as you get to 10, the baby's head still has to come down the birth canal. So if you begin pushing right when you're 10 centimeters, you're pushing for a good 3 hours, especially for your first baby. Plan on it, 2 to 3 hours. So during that time, what happens? You get tired, your labia gets swollen, your vaginal tissue gets swollen and inflamed. You end up probably getting a vacuum delivery because you can't push the baby down and you're tired at that point, so your effort is pretty low, and you end up tearing pretty substantially. Or you're so exhausted and you don't push well, and then you end up having an unnecessary C-section because you're exhausted and the baby's head is too high for us to have it to do a vacuum or to help you. So I tell all of my patients, and all my nurses know this is how I practice on labor and delivery. When a patient gets to complete dilation, we let her labor down. So what that means is we don't have her push for 2 hours, 3 hours even. We just let her hang out there. And if she's got an epidural, great, she can rest and sleep. And if she doesn't have an epidural, she'll continue working on breathing and squatting and doing some different positions. And when the baby will come down with gravity, even without pushing, your baby will come down with gravity. And then when a patient tells us, I feel like I want to push, I have the urge to push, I feel the pressure, the rectal pressure, that's when we have to start pushing. The less you push, the more likely you are to have a vaginal delivery. And that's, if there's one take home advice I can give you, that would be it. It's like laboring at home. Laboring at home and then laboring down. The other thing I always tell my patients to make sure their doctors do is to do delayed cord clamping. It's become customary now. So like at St. John's where I practice, as soon as the baby's out, they actually start timing us. And then when we get to the 1 minute mark, that's when we're told to clamp the cord. I go a little bit past 1 minute, but we've learned that delayed cord clamping is so important because it gives such healthy blood flow to your baby, and it helps with prevention of anemia. And during this time, the baby's just put on mom, so she gets that delicious skin to skin time. And if you're planning to do cord blood collecting for stem cells, we can still do both, so it's not one or the other. Um, Also, I encourage my patients to put on their birth plan like hands off. So what does that mean? It means you don't need a lot of pelvic exams during your labor. You don't need to be checked every hour by a nurse to say, oh, you're still 3 centimeters. An hour later, oh, you're still 3 centimeters. No, you don't need to be checked that much. First of all, I think it causes a lot of anxiety for patients because they don't feel like the progress is happening. But it's slow and steady. Progress is slow and steady, and that's okay. We're not on a race. When you get anxious and when there's a race that happens by your medical team putting that pressure on you, that doesn't work. So I tell my patients, we're going to check you when you come in, and the next time we check you is when you're in pain and you're like not smiling. And then the next time you'll be checked is like maybe if it's been several hours and there's no baby, but it should be like sparingly. And especially if your water bag's broken, you don't want a lot of pelvic exams because of the introduction of infections. And then lastly, I would just encourage my patients to really tell their doctor they want skin to skin contact. So even if you're doing a C-section, like I did a C-section this morning, it was her second C-section, so it was scheduled and planned. As soon as the baby was born, we put the baby right on mom. There is no reason to take the baby away from the mother to do the measurements, you know. And one of the nurses was saying, "Oh, I'm going to take the baby to do the vital signs." I'm like, "Nope, you can." Even though I'm operating, I like heard that. I'm like, "Nope, just bring the thermometer and your things over to the baby on mom, and you can do it all there. The thermometer can move. Your stethoscope is right around your neck. Do the vital signs on the mom," because it's so nice for her to just have her baby on her. And I also think it's great during surgery that she also gets a little bit distracted from what we're doing. It's just, I always think the babies need to be with mom. They can always be weighed later. That's the weight's not going to change by a significant amount. So the head size is not going to change. So even though nurses have their checklist, just really say that you want your baby with you at all times.
Awesome. Those tips are so helpful. And I think I actually just had a friend that had a baby yesterday.
Mhm.
And I'm sure this would have been very useful for her. And I know you've touched on some of these, but maybe if you just want to, I know we had a lot of questions ahead of time of sort of like the pros and cons of a C-section versus vaginal delivery, and just, you know, like how to prepare for those kinds of things. So I know you've touched on some of these, but any other just tips or things that you want to flag around reducing the risk of C-section?
Well, we're definitely working very hard at the hospital to reduce the C-section rates. You know, now we have a perinatal committee, which I'm on, where every single doctor's C-section rates are analyzed and sub-analyzed because we're trying to reduce C-sections. C-section rates were climbing drastically throughout the country. You know, starting in 2011, 1 in 3 women were having a C-section. That's a high number. And it's not just one C-section, but if you have more babies, which many women do, with subsequent C-sections, especially number 3 and number 4, there are complications that can happen. And we wanted to make sure that doctors and patients were understanding that C-sections are a major surgery and that doctors can do things to actually lower the C-section rate. And so there's been a lot of education and a lot of revisiting the whole labor process and the labor curve of doctors so that we as doctors take ownership for being responsible for our C-section rates. Our C-section rates are published publicly for all of our patients to see, and you know they do that, and the hospitals are very careful about doing that. The average C-section rate in the country is about 25%. So hospitals are trying really hard to lower that risk to lower that rate to less than 25%. And some hospitals, especially the ones that you know we do a lot of high risk deliveries, those can be upwards of 40%. I found that my C-section rate 4 years ago, I should say, was 19%. And that was high for me. And I, at that point, because I was on the committee, I was like, I need to look at how I'm doing things and change a few things. And I'm so happy with the changes that I've made, big changes. My C-section rate is now 3%. So I'm
Wow.
really proud of how it's like the lowest C-section rate at the hospital. And I am one of the busier OBGYN. So my
We know we used to ask lots of patients, and I feel like you pick up while you're over at you too.
it's a lot of babies. That's
Yeah.
why I buy a lot of dry shampoo these days. Um, but with the C-section rate, the biggest thing I did that was different is I stopped inducing patients. So I used to tell patients, okay, you're 40 weeks, like let's get you induced. You're getting past your due date. But now I wait till 41 weeks, and I even go a little bit past 41 weeks because the standard of care is after 41 weeks, nothing good happens. There's meconium, there's a risk of stillbirth, the placenta gets old. But between 40 and 41 weeks, we can monitor a patient at the hospital, check her amniotic fluid, and do some surveillance to see if we can get to 41 weeks. And then during the 39 to 41 weeks, I work very hard with my patients to have them do other things to help bring on labor. So I encourage acupuncture. Exercise is so important, like walking up hills to bring the baby's head down. Pineapples, there's this ingredient in pineapples and dates that brings on labor. Don't ask, but all my Chinese acupuncturists swear by it. So I've gone along for that ride and recommend spicy food. Don't eat Indian food though. That's another story in another Zoom call, but don't eat, I can say this because I'm Indian, but don't eat Indian food before you go into labor. It's not recommended. And then also, doing acupuncture. Acupuncture is great to have certain triggers to help bring on labor. And then I usually strip my patient's membranes at 39 weeks, which means I can do a pelvic exam and scratch the cervix and try to help release some prostaglandins. And the biggest thing that patients can do to help bring on labor naturally would be to have sex. It really works because when you're intimate with your partner, it's not the act of sex, but it's semen, and it's got prostaglandins that can help bring on contractions, which is why oftentimes when you're pregnant and you're intimate, patients will call us saying, "I'm having cramping," and or spotting, and that's normal. And then another thing to really reduce C-section risk is to avoid excessive weight gain. Like, you guys, the onus is on you because we can only do so much. But if you gain an excessive amount of weight, that means you're having an excessively sized baby. And you don't want a 10-pound baby vaginally. Even if we could do it, you don't want that. The physical therapy place will tell you that also. So try to manage your weight gain so it's 25 to 35 pounds. Make sure you're exercising throughout your pregnancy. So when you show up for your marathon, you're not somebody that hasn't worked out and doesn't know how to, get a heart rate up. So make sure you're doing that. And then also to reduce the C-section rate, really, again, I cannot emphasize this to you enough, finding a doctor that shares your philosophy and is willing to go the part with you.
Yeah, we had a question around that was, around ensuring your wants and needs are met, knowing that you might have a rotating cast of like nurses or different providers in the room.
The main person is the doctor, because the nurses aren't able to truthfully do anything to a patient without the doctor's permission. So a nurse cannot start Pitocin or stop Pitocin or start a medication without us saying start this medication. And we work in partnerships. I'm not putting us versus the nurses, but it's really as the doctor that's going to set the tone for your delivery. I always the same doctor who told us about an easy vaginal delivery or an easy C-section, he also gave me the best advice. He's like, when the nurse calls you at the hospital to say the baby's heart rate is down, don't run. He's like, walk really, really slowly to that patient's room. Because when you run, the baby's heart rate will still be down, and then you're going to get panicked and things will start to happen. But if you walk really slowly, by the time you walk and you're like calm and you walk in, so the patient sees the doctor's calm, and 9 out of 10 times that heart rate's going to be back up again. So a lot of times that you have to have experience to have a tolerance for what is concerning on a fetal tracing and what isn't. So not overreacting to the way a baby looks. And babies get tired during labor. So there are things that happen during labor where a baby's heart rate starts to get a little bit low. And there's a lot of uterine resuscitation we can do for a baby while they're inside mom to help them. We can turn down some of the medications. We can do position changes. We can give oxygen. We can put fluid inside the uterus to help them get extra fluid if their amniotic fluid is low. We can change positions, and just most of all, being patient. And 9 out of 10 times, those babies don't need C-sections. We see that because if you take a patient to the operating room for an emergency C-section because the baby's not tolerating labor, those babies come out pink and crying. And we always want a baby to come out pink and crying, but you realize that, I don't need to do that C-section. We could have waited a little bit. C-sections, I'm not trying to disparage C-sections. I do C-sections. My patients that are listening on this have had C-sections. C-sections are life-saving. They save a baby's life. And if you need a C-section, if you've had a C-section, and if you end up with a C-section, do not feel shame and do not feel stigma about it. A C-section is a life-saving procedure for your baby. And sometimes you don't have a choice because the baby's position is a certain way. If you have twins, there are lots of reasons why C-sections happen. And the most important priority all of us should have is healthy baby, healthy mom. There's no point doing vaginal deliveries and having a low vaginal delivery, having a high vaginal delivery rate as a doctor, but then the next list of statistics should be, well, how many of those babies are in the ICU? How many of those babies have poor outcomes? How many of those moms have poor outcomes? And that has to also be looked at, because that you can't have low C-section rates, but then have bad outcomes with the moms and the babies. And I have to tell you that your number one priority is to trust your doctor, trust that they're there to take care of you. You'll build that trust. And if you ever feel like you're not being heard, if you ever feel like you have a doctor that's forcing you to get induced, for scheduling reasons. Like, if I go away and go out of town, I tell my patients, I'm not going to induce you because I'm going out of town. That's not a reason to be induced. You will meet the doctor that's going to cover for me, but we're not inducing you based on that. That's not the right reason. Fine. And also I've had patients that switch to me, and you can switch to other doctors even in your third trimester. If you're feeling like your philosophies are not meshing, that's, you need to sort that out so that when you go into labor, the last thing on your mind is worrying about your doctor and feeling like you have to hire a doula who's going to be your advocate against your doctors, like who's going to be there to speak up for you in case your doctor says something that you don't like. You should be able to speak up to your doctor. You should be able to say, hey, I want to do this, and let me tell you why, and feel heard. And if you're not feeling heard or seen by your doctor, it's time to switch.
Awesome. Well, I know we still have about 5 or 10 minutes left. So we had a bunch of Q&A. If people have questions, feel free to put it in the chat or in the Q&A. But I'll just start with some that we got from registrants ahead of time. So one was, how is labor for a second pregnancy treated differently than a first time, if there is a difference?
Well, labor for second pregnancy, if it's a vaginal delivery, if we're referring to that, is always a lot faster and a lot easier, a lot faster. So for patients who have trauma from their first delivery, that they pushed for a long time, they had a big tear, it was really painful, I promise you it will be so different and so easy that you'll want to have your third baby. 9 out of 10 times that's going to happen. It'll be fast. So don't wait for too long at the hospital. But if there were things in your labor that didn't go well, or that you were concerned about, or that were problematic, review that with the doctor. So if I have patients who had a problem with the anesthesiologist, even before they go into labor, I'll have them meet with the anesthesiologist the second time so we can kind of problem solve what went wrong or what wasn't right. And then this way she has a much better experience. And that's really important, to make sure the second experience is always better and they feel like, because they know more as well in the second pregnancy. So, in the second delivery, I should say.
Yeah. And there was a question around how many cervical checks are necessary versus desired to check dilation progress. I know you touched on this a little bit, but would be curious there.
And from 0 to 6 centimeters, and you again don't know what 6 centimeters is, but I think you just need one exam and admission, and the next exam should be when a patient's either like thinking about an epidural or like in pain. So if she's talking through those contractions at the hospital, I'm not checking her because she's not going to be making significant change. And then of course, when your water bag breaks, you want the bare minimum exam. So no more than like every 4 hours.
Awesome.
4 to 6 hours, even spaced out more.
We had a lot of questions about how to induce naturally. I know you touched on some of those, but are there any other tips for how to induce naturally at 40 weeks?
So I would say if you want to start inducing naturally, don't start it at 40 weeks. It takes a few weeks to actually work. So I tell my patients starting at 37, 38 weeks. Number one is sex, nipple stimulation, spicy food, but not Indian. Pineapple. I have trauma from that one birth. So, spicy food, pineapples, dates, walking up hills, acupuncture, and then getting your membrane stripped by your doctor.
Awesome. And then we had a couple also around just pain management. So most effective pain management tips, or how to reduce pain without medication, like counter pressure, different positions, etc.
The positions are essential. So if you're somebody that doesn't want to get an epidural, or you're waiting to get it and it's still very early in your labor, I encourage you to, again, labor at home, manage it at home better. So through the hot baths and hot showers, and then using things like massages, music, essential oils actually work to kind of just calm you down, using your breathing techniques that you learn from birthing classes, and then different positions like lying on your side, using a peanut ball, which is something that we use at the hospital quite a bit, helping the baby down, bouncing on the birthing balls that are also really helpful, rocking on a chair, and then walking around. So you're not sitting in one position, and using massages and having either the doula or your partner have him massage your neck, and then using a lot of warm compresses as well, and just one step at a time. And then if you do decide the pain is too much, there is literally nothing wrong with you saying, okay, I reached my hard stop, I'd like something more. It's like showing up to the dentist for a root canal and then asking to like do it without pain medicine. It's great if you could do it, but medicine is so you can get help. And when I think of natural deliveries, I don't think there's anything natural about being in severe pain. So I always think of natural deliveries as a vaginal delivery with minimal amount of intervention possible.
Yeah, we had a question around what we were just touching on, which was the sort of when to get that epidural. So one panelist asked, regarding the phase when fully dilated, you said that pushing doesn't necessarily have to start yet, and one option is to get an epidural and take some rest. Isn't it too late for an epidural? I heard there's a time limit to get it.
No, I've given patients an epidural when they're 10 centimeters dilated. So if they want it and patients ask for it. Now, if you're like, it's your second or third baby, I'll sometimes tell patients, look, by the time you get this epidural, the baby's going to be between your legs. So let's just push and let's have a baby. And it depends on each scenario. But if she's like really struggling and feeling anxious, we're happy to give her the epidural. The anesthesiologists are so great at the hospital. They can get it in 7 minutes easily. And then she can get comfort. Oh, and then also, I didn't say this, but this is important. If you do have an epidural and then it's time to push, it's very hard to push if you can't feel anything and if you're numb. So the other thing I do with my patients, and you would definitely put this on your birth wish list and tell your doctor that you wanted this, is to have them lower the epidural. So by lowering the epidural, they don't have to turn it off, but they can start decreasing the dose in your epidural catheter by half. Then you'll start feeling more pressure, because it's really hard to push when you can't feel anything.
Yeah.
And then also, like when the nurses sometimes are with you before the doctor gets in there, a lot of nurses will put their fingers in and push really hard and like keep their fingers in for every contraction and like do this to your perineum. And they're like, okay, like they sometimes even use two hands and push and spread the the vaginal walls out. That can cause a lot of birth trauma. So what I've seen when that happens is the tissue gets really swollen and raw and they tear a lot in the inside. So once a patient knows how to push, we don't need to put our fingers in. Like they got it. Just, encourage them to push. I wanted to just add one more thing, Allison, about C-sections. I don't want this to be like that C-sections are bad. There's a role for C-sections, and there's a big benefit to C-sections. C-section patients will never have sexual dysfunction. They will never need to go to physical therapy, to be honest, because they're not going to be struggling with the urinary incontinence or the pelvic prolapse or any of those things that can happen. In fact, now when we do C-sections on patients, there is a role for some patients having a primary C-section. Patients who've had sexual trauma, patients who have had anal fistulas or pelvic floor surgeries that preclude them from having a vaginal delivery. We encourage that. If patients, we know they're having a big baby, we give them the options. But we always tell patients, be careful, because the ultrasounds can be wrong by 3/4 of a pound. So if a doctor tells you, oh, your ultrasound shows 9.5 pounds, you should do a C-section, I would still try to have a vaginal delivery. But C-sections are not bad, and the most important thing is to, again, have a healthy baby, healthy mom.
Totally. And we still see patients all the time too, who after C-sections, need help with scar mobilization or like desensitized and all that. So we love all forms of delivery. Okay, I think we have one more question and then I will close it out. But we had one, and I don't even know what this is, so I will be excited to learn more, but how to improve the chances of successful VBAC. I don't even know what a VBAC is, so I'm very curious.
So a VBAC is a vaginal birth after a C-section. So sometimes patients will have a C-section for many different reasons. The most common being that, the baby didn't tolerate labor, or the labor stalled out, or if the patient was breech. So many patients who have a C-section the first time have decided that they want to have a vaginal birth after a C-section. So it's really important that you do this safely, because there is a risk that can happen, and it's a rare risk. It's called uterine rupture. So what that means is the scar on the uterus, even though it's repaired when you're in labor, with every contraction, that scar can expand and relax, and it can rupture. And when it ruptures, we're not inside you, because we're just looking at you on the outside. The baby can be slowly expelled from your uterus. The baby can die. You can have an emergency hysterectomy because you're bleeding internally. The baby can be born with cerebral palsy. It is catastrophic when that happens. So I tell my patients, if you want to be back, you are delivering in a hospital. Do not even contemplate doing a home birth. Never. And then if you have a VBAC, if you're planning to do vaginal birth after C-section, you want to work with a doctor who's open to that plan. Normally, if we do a scheduled C-section for a patient who wants to have a second C-section, we schedule it at 39 weeks. So for patients who want to not have a C-section or who want to try to have a vaginal birth, we encourage them to go to 40 weeks. So at least wait until 40 weeks, maybe even a little bit past 40 weeks, to see if their body can go into labor on their own. It's not recommended to induce a patient because the medications we use to start labor, like Pitocin, are so strong that it could increase the risk of uterine rupture. But once the patient's in labor, she can actually get Pitocin and other things safely to help her go along with labor. But you want to have continuous monitoring in the hospital so we can monitor you and make sure the baby's heart rate looks good. And we've done successful VBACs and patients do really well. I always tell my patients it's harder to be in the throes of having a vaginal delivery and then have it converted to a C-section, because it's like that marathon analogy. It's like running for a marathon and you're almost at the finish line. You're at mile 24, and then somebody comes into your room like me and says, okay, now we're going to run 10 more miles because now you're going to go to the operating room. So that's hard. But I do think if patients are willing to do a VBAC, it's great because you go home the next day. It's a better recovery. You just have to be the right candidate and make sure you discuss the pros and cons with your physician. And to summarize, the most important thing would be not to schedule your C-section too early, to do it a little bit past 40 weeks, and then do the other things to bring on labor, like acupuncture, sex, spicy food, citrus, walking up hills.
Wonderful. Well, thank you. I think we are right at time. This was so helpful. I learned so much. I will be sure to share this recording with everyone who registered and attended as well after this, so we can get these incredible tips from Dr. Amersi. But thank you everyone for joining us. If you have any questions, feel free to always reach out. We are info@theoriginway.com. But hopefully look forward to seeing you all soon. Thank you.
And good luck, everybody.
Thank you.
Yes, good luck for all the future moms.
Yes, congratulations.
Thank you.
Bye-bye. Thank you for having me.
Yeah, thank you.